I want to welcome everybody to our symposium for patients with melanoma and their family and friends. We're very honored and grateful to have you here both in person, and we've got a slew of people online. We've done this for many years, except when there was that little pandemic going on. We had to skip a couple of years, and our goal is twofold. Oh, I didn't even introduce myself. I'm Paula Landman. I'm the nurse navigator with the melanoma program here at UNC Cancer Hospital. My partner in crime, Trish Long, who's the nurse practitioner with the surgery oncology program, is usually here with me, but she could not make it today, but she's cheering us on from afar. So our goal here is twofold. One is educational. Hopefully you'll leave here with a little bit more knowledge about a lot of different aspects of melanoma and cancer treatment. And our second is to give you an opportunity to connect with other people who might be going through something similar. Most of my patients have never met another person with metastatic melanoma, and I think it can be very isolating. So hopefully you'll get to chit chat with people that you're sitting with, and during the break, introduce yourself. We all have our name tags. Let's see. Looking at my cheat sheet here, it says to speak slowly because I speak too quickly and get very nervous. It's a very laid back venue, and we really encourage people to ask lots of questions. If you need to take a break, just feel free to use the facilities, and we will have a snack time at about 2 o'clock. I do want to thank quite a few people for making this happen. Most importantly, the Melanoma Research Foundation, who's offered financial support as well as, logistics support, technology support, and emotional support. Also, we have some pharmaceutical companies that have donated some of the items you see at the front. One of my patients donated about 200 pins to our conference and to our patients, the melanoma ribbons. And I have another patient who printed up these beautiful bracelets that you saw out there that say, pray more, worry less. So for those who that might be meaningful for, please take. I want to introduce Kylie Lapira. She's with the Melanoma Research Foundation, and she's going to let you know about some of the amazing stuff that they do.
Thank you, Paula. And just a big thank you to UNC. As Paula mentioned, we've hosted this event here for many years, and UNC is a wonderful partner, and the work that they do for melanoma patients and caregivers is just extraordinary. So I just wanted to thank you, Paula, and your team for pulling together today's speakers and really orchestrating this wonderful event. And we're also thrilled that people can join us online who might not be able to be here. And we have a very nice large group joining us virtually today. So as Paula mentioned, my name is Kylie Lapira. I'm the CEO of the Melanoma Research Foundation. We are based in Washington, D.C., but we are a national foundation, and we meet with patients and their loved ones all over the United States. And I'm particularly happy to be here with you today because it's May 1st, otherwise known as Melanoma Monday, the kickoff to Melanoma Awareness Month. And this whole month, we will be sharing information and resources with not only the melanoma community, but the general public about melanoma awareness and education, prevention, and early detection. So really happy to be with you all and on a really important day for our community. So I would also like to thank our sponsors. These are our corporations who generously support the Melanoma Research Foundation's Patient Symposia series. So we host meetings like this all over the country. In fact, we do 6 cutaneous melanoma symposiums each year. We'll be hosting our next one in Seattle at the Fred Hutchinson Cancer Center. That'll also be another hybrid event. We're also hosting one at Case Western and Cleveland Clinic in June, and then we'll be hosting another 3 in the fall. We also host a patient symposium for our pediatric melanoma patients, as well as our adolescent young adult patients, and our uveal melanoma patients, which is melanoma in the eye. So many of you might not know what the Melanoma Research Foundation does or who we are. So I wanted to give you a little bit of an overview. We were founded by a patient over 26 years ago. Her name was Diana Ashby. She was a young woman in her 30s dealing with her 3rd recurrence of metastatic melanoma. And unfortunately, at that time, there were very few treatment options, and there were very few funders in the melanoma space outside of the government. So she, together with her friends and family, started fundraising and thus formed the Melanoma Research Foundation. So in the beginning, we were a funder. We were one of the only funders, really, one of the only private funders of melanoma research. And over the years, our mission developed because there were more funders that came into the field, which is a wonderful thing. But unfortunately, the diagnosis rate of melanoma continued to increase, and patients were really seeking more information about the disease. Caregivers wanted more information to help care for their loved ones. And really, there became this gap of need for the community. So we became an educator as well. At the same time, we started advocating for melanoma patients on both the state and federal level. And I'll tell you a little bit more about that in a second. So as I mentioned, we are national. So we have patients, caregivers, loved ones all over the United States, helping to educate people in their own communities about melanoma, but also creating awareness for the disease. And there you see some of our advocates doing multiple things, whether they're running a 5K or our little ones at the Pediatric Melanoma Summit, or sharing their story with lawmakers on Capitol Hill. So to touch on a little bit of our research, which is the first pillar of our mission, to date, we've funded over $23 million in research grants. Those have gone to hospitals all over the country. We also involve patients in our research grant review process. So this is going to be my shameless plug to you all. If you would like to get more involved in research, you can sign up to be an advocate reviewer and help us review research grants and help determine some of the research that we're going to fund. So that's my little plug if you want to get more involved. We also host scientific meetings and workshops all over the country on specific topics. Education. I talked about this a little bit earlier. So we are a major educator of not only melanoma patients and their loved ones, but the general public on melanoma. All of our education materials are free. You can order them through our website. We will ship them to you. We can send them to your doctor's office directly, but we have a whole host of materials, again, that are all free of charge. We're really excited right now because we are redoing our patient and caregiver guides. And again, those will be available for download or to ship to you at no cost. I mentioned advocacy a little earlier, and I just wanted to share a little bit more about what we do as an advocacy organization. So we have 4 areas that we focus on. One is research, and that's getting funding through the federal government, specifically for melanoma research. Melanoma used to be lumped into a fund for rare diseases. So every year our advocates would have to share their stories and advocate for melanoma funding. 4 years ago, because of advocates like you all, we were able to get that funding pulled out to its own separate line item through the Department of Defense. And that line item grew from $10 million to $40 million this year. So that's $40 million for melanoma research through the Department of Defense. And that's because of people like you, people who are passionate, who share their stories with lawmakers. And that's how we were able to do that. So that's an incredible amount of funding for melanoma research. And I'm sure some of the researchers who are going to be talking to you today can attest to that. Access is another pivotal area that we work with our advocates on. So access to clinical trials, access to treatment options, access to telehealth, which is a big issue now that we're coming off of COVID. Education, so educating our advocates on the issues, and prevention. Many of you won't believe, but a lot of children are not able to take sunscreen into schools because it's considered an over-the-counter drug. Again, that's a state-by-state issue that we're working on. Tanning beds for minors under 18. We're working with the FDA right now on a federal tanning ban to ban all minors in the United States from using tanning beds. Again, it's a state-by-state issue. It's completely unregulated. So some of you who may follow us on social media know that we are known for our #GetNaked campaign, and we have somebody here proudly wearing one of our t-shirts. This is all about creating awareness about melanoma and getting people to not only check their own skin each month with a monthly skin check, but seeing a dermatologist once a year for a full body skin screening. So we unveiled our new spokesperson today for our Get Naked campaign. So if you follow us on social media, you probably saw that big announcement, but this year's spokesperson is Teddy Mellencamp. She's a stage 2 melanoma survivor, a young woman. And again, melanoma is one of the top 3 leading cancer deaths in young women. So it's very important that we educate that group. We also have awareness campaigns in some of our other subtypes as well, like pediatric melanoma, ocular melanoma, and mucosal melanoma. So with that said, I just want to again thank this group so much for being here today and hopefully imparting this knowledge on your communities too, and sort of paying it forward and creating awareness about this disease. You'll see our social media handles on the screen. Again, if you learned something interesting today or want to share that you were here, please feel free to tag us on social media so we can share that with our wider community as well. So again, I want to thank you all, and I'll be here all day. So if you have any questions about what the foundation does or resources, I would love to talk to you. And with that, I will turn it back over to Paula.
Before we introduce our first speaker, I just wanted to take time to do 2 things. One is, in our audience here, we have several people who had spoken, several patients who have spoken at previous melanoma conferences. And I wanted to ask them to either stand up or wave their hands so we can acknowledge them, and we're very joyful that they're with us here today again after many years. So okay. I also want to take a moment. We have made great strides in melanoma treatment. It's really been incredible the last 10 years. Unfortunately, we have lost patients along the way to melanoma, and I just want to take a moment of silence to honor their memories and to keep those people in our hearts, or anybody else that you have in your hearts and thoughts right now. So just a moment of silence. Thank you. I want to introduce our first speaker, Dr. Scott Chen. He is new this past year to our radiation oncology program here. He's been an amazing, wonderful asset to that team, as well as to our melanoma group here. And he's going to discuss advances in radiation treatment for melanoma. Yep.
Well, thank you all so much for being here, and really appreciate the invitation to be here and speak to you all. And I'm really grateful for being able to take care of some patients with melanoma. And I really want to thank all of you for allowing us to be part of your care and to learn from you and to be better doctors to treat this sometimes devastating disease. The title of my talk today is Advancing Radiation Treatment, and I'd like to briefly talk about how we as radiation oncologists contribute to the care of patients with melanoma. And I have no disclosure, and I wanted to start with just broadly, how is cancer treated, in particular, how is melanoma treated? And usually when we think about treatment for cancer, there are 3, I think of three branches of medicine: surgery, which are practiced by surgical oncologists, and which we all know they use scalpels to remove the tumor that we can see. The medical oncologists use drugs. They deliver pills or infusions to treat cancer, and they are also an important part of the team. And when we talk about radiation oncologists, oftentimes the reaction I get is, what are radiation oncologists and what do they do? So I guess one of the goals of today is to tell you a little about radiation as an important treatment for cancer, and in particular melanoma. And as some of you may know, up to 50 and 60% of all cancer patients might need radiation treatment at some point during their journey through cancer. And I'll also discuss in particular when and why we might use radiation to treat melanoma. And I also want to give you a sneak peek at what radiation oncologists do and what we are working on to make this treatment better and work better for melanoma in the future. So the radiation, as some of you might know, was discovered very, very long time ago. Very shortly after the discovery of radiation, and both man-made radiation and natural radioactivity, we started treating cancer patients with radiation, and it's surprisingly a very old field. And as you can imagine, before we invented any CAT scans or PET scans or MRIs, most cancers we can detect are the ones we can see, and most of them are skin cancers. And actually, skin cancer was the first type of cancer that was treated by radiation. So at first, we didn't have any ways to generate radiation other than the naturally occurring radioactive materials from mines or minerals. But after many, many years of research, people were able to invent machines that can deliver X-rays and use those to treat cancer patients. And that is actually a huge advance in the field because as we all know, we can't really turn on or off the radioactive materials, but we can turn on and off the machines. And that allowed the dissemination of radiation as a treatment modality for cancer more broadly all throughout the world. So this, as you can see, is one of the first radiation treatment machines ever invented. And yes, exactly. So it's not exactly the most high-tech, well, I'm sure it was the most high-tech thing at the moment, but this is definitely not what we do now. And this is probably some of the inspiration from which the famous James Bond movie was created. So as a comparison, this is what we use to treat cancer nowadays with radiation. This is what we call a linear accelerator, and it's very, very compact now, and it's probably the size that we can fit probably in all of our living rooms. Not that I'm advocating for putting one in your living room. It needs a lot of shielding. So, but anyway, the treatment has become very much more precise and very much more palatable, and I'll go into a little more details in a little bit. So, how does radiation work in general? Radiation damages the genetic material of all living cells. And the trick that we exploit as radiation oncologists is that cancer cells are often bad at repairing those damages, while normal cells are more capable of repairing themselves after or between radiation treatments. So we often deliver radiation in small quantities, as we call them small fractions, every day or every other day, to allow the repair of normal tissue to occur while we're killing cancer cells. So a typical radiation course is sometimes can be a few weeks long, given daily, Monday through Friday. Focused radiation is sometimes given in only one or a few treatments, and we call those radial surgery, and I'll tell you a little more about those too. And the reason we can do that is because the technological advancement have allowed us to really focus the radiation beams onto the tumor and cancer that we can see, and really minimize the amount of side effects from radiation. So you might have heard some of these abbreviations from radiation oncologists or from your oncologist or from some other people, and it's really a soup of random letters, as you can imagine, and I don't expect any of you to know any of these. But suffice to say, these are all different technologies that we use to deliver sometimes focused radiation or sometimes more broadly to a general area. And these are ways we have made progress in the past. I do want to make one distinction, that is the IMRT, which is typically a longer course of radiation treatment over a few weeks, versus SRS or stereotactic radial surgery, or if it's somewhere else in the body other than the brain, we would call that SBRT. So those are delivered, as I mentioned before, a focused type of radiation within one treatment or a few treatments. So if you are, or anyone you know, are receiving radiation treatment, this is typically what you can expect. The first step of radiation is what we call a CT simulation, which is a special CAT scan that's usually done within the department of the radiation treatment. And after that, we use that CAT scan to make a 3D model of the body and of the target that we want to treat. And after that, we invite you back to the treatment machine, that looks just like this. And you would lay on a table, and the machine would rotate around you. And during that rotation, two things occur. One is we can get a very fast CAT scan right there while you're laying on the table. And usually we do that every time you're getting treated. And the goal of that is to make sure we can localize where we're targeting and make sure we're not accidentally targeting anything else we are not intending to. And the second thing that can happen is here, the circle here is what we call the head of the linear accelerator. That's actually where the X-ray comes out. And while the X-ray comes out, on the right-hand side, these are very, very thin metal beads that can shape the radiation field right exactly when the machine is rotating. And it allows us to shape the radiation field in such a way that it conforms to the shape and size of the tumor that we want to treat, and really spare the rest of the body very nicely. So the final product is what we see here. And as some of you might not be familiar with CAT scans or PET scans, this is actually a CAT scan through the lungs of a patient. And the black parts are the lungs, and there was a tumor right in the middle of this lung. And the color that you see here represent different amount of radiation, and it's labeled quite intuitively. The more you go into the center of the tumor, the higher the radiation dose, and the cooler areas, or the areas that are getting lower amount of radiation, are the blue. And as you go further and further away from the tumor, the rest of the lungs and the rest of the body are really getting a very minimal amount of radiation. So I've been asked some of these questions quite a few times, so bear with me. Will I be radioactive after radiation? No. Once the machine is turned off, there is no radiation in you or in the room anymore. So the second question is sometimes more challenging to answer. Will I become an incredible Hulk or glow in the dark? And unfortunately, the answer is no, because we're still trying to develop the technology to do that. will I get very sick or lose my hair? Typically, no. But it depends on exactly where we're aiming the radiation. So suppose if we're trying to treat a tumor in the brain, there is a small chance that nausea or hair loss might occur. But again, as you will hear later on, usually in that case, we're using a technique called SRS, or stereotactic radial surgery, which really focuses the radiation on the tumor and spare the rest of the brain. So nowadays, the chance of you getting very sick or losing hair or having any other side effects are really quite minimal. And the last, but I think more important thing to ask, especially to discuss with your radiation oncologist, is what the goal of radiation is, whether radiation will help me live longer. Oftentimes the answer is yes. The reason we want to give a patient a treatment is to help them live longer, but sometimes there are other reasons to give radiation. For example, if there is a tumor pressing on an important nerve and causing pain, or if it's causing any problem with breathing, for example, we can also give focused radiation to relieve the pain, shrink the tumor, improve the breathing. And in those cases, radiation can actually be quite helpful, even if it may not extend the patient's life. So it's always important to discuss both the potential side effects, which are typically minimal, and why we're recommending radiation. So how do we use radiation to treat melanoma in particular? When melanoma is limited to its original location, or typically on the skin, the treatment is surgical, as you will hear from Dr. Olila later on today. And sometimes we do what we call a sentinel lymph node biopsy, or essentially a surgery to remove some of the lymph nodes. And sometimes we see cancer cells in the lymph nodes. And in those cases, there have been studies showing that radiation can help preventing melanoma from growing back, or in this case, it can help clean up the scattered cancer cells that the surgeons can't see with their eye. So again, the reason that helps is to prevent cancer from growing back in the original location or in the lymph nodes. However, right now, we typically don't give radiation in this type of situation anymore. We have found that sometimes it's just okay to observe patients with, for example, ultrasound every few months, or in other cases, we can give other treatments, for example, as Dr. Sora will discuss later on, immunotherapy or other type of therapy that can help patients live longer and prevent melanoma from growing back. So there are, however, instances where we do think radiation make a bigger difference, and brain is one of them. And the brain is actually a common site of spread for melanoma when it starts to spread elsewhere. And brain metastasis is usually uncommon in patients with early stage melanoma. But however, there can be up to 50% of patients who might develop metastatic melanoma in the brain, in which case, sometimes it's hard to treat surgically because not everyone is able to go through a surgery in their brain. And sometimes the drugs don't penetrate the brain very, very effectively. But that is also an evolving target. Nowadays, there are drugs that can actually go to the brain and control some of the small melanoma spots in the brain. But regardless, radiation is actually a main treatment for brain metastasis from melanoma. And there are two types of radiation that we can deliver, and I will talk about for brain metastasis. And the first one, which is really the gold standard nowadays, is called radial surgery, as you might remember from before, SRS. And it is advanced, as I mentioned, advances in technology have allowed us to really accurately target brain metastasis with surgical precision, because initially the person who invented the technology, or SRS, was a neurosurgeon, actually. SRS, which is delivered to the brain, or SBRT, when we deliver that to other parts of the body, can be given in one treatment or up to 5 treatments. And here at UNC, we typically use a technology called CyberKnife to deliver this kind of radiation. And you can see the source of the radiation in this case is mounted on a robotic arm right here. And it can be aimed at many different potential angles and really focus radiation on the tumor itself. And this is just what it looks like when we plan the radiation. And as you can see, the high dose radiation really just falls onto the tumor itself as opposed to elsewhere in the brain. The other type of radiation treatment before we were able to invent this focused radiation is called whole brain radiation. As you can imagine, the target in this case is just the brain itself. And nowadays we use this technology much less frequently, but sometimes it can still be useful. And those are if the brain metastases became too large or too many, and sometimes it's hard to do focused radiation on all of them at the same time, then we might consider treating the entire brain with the radiation. And this is typically done over 10 daily treatments over 2 weeks. And as I mentioned before, if we have to treat a larger area of the body, you can sometimes do expect a little more side effects. And those can include hair loss, dry mouth, memory loss, and fatigue. And sometimes those can be quite significant, which is why we don't use this type of treatment very often nowadays. So that's just a typical treatment calendar for this type of treatment. We do have other ways to minimize those side effects nowadays without using the stereotactic radiosurgery. On the left-hand side is the way we typically deliver whole brain radiation, say 10, 20 years ago, which is essentially just 2 beams coming from both sides of the head, and they meet in the middle, and the entire brain is treated sort of to a homogeneous dose. But nowadays, we actually have developed another technology that can treat the entire brain and spare the area that are in charge of memory and executive function, which is the hippocampus, and really reduce the amount of cognitive side effects from this type of treatment. And this is the radiation plan from that type of whole brain treatment. As you can see, most of the brain are receiving a good dose of radiation represented by red and yellow. And there are 2 cold areas in the center of the brain. Those are the hippocampus. And we have actually done a number of studies to show that this type of treatment can indeed reduce the cognitive side effects from whole brain radiation. As I mentioned, radiosurgery can also be delivered to other parts of the body, in which case we call it SBRT. Please don't ask me why we generate so many acronyms, and that's just how it goes, unfortunately. Sometimes melanoma can move to the lungs, can move to the liver in the middle pane, and it can go into the bones, and sometimes, unfortunately, to the spine. And in those cases, we can do radiosurgery to those areas as well. So those are the past and current status of radiation treatment for melanoma. And I also want to give you a little bit of sneak peek of what's in the future and what our other radiation oncologists are working on in terms of how to make this a better treatment for melanoma. And one of them I think is very promising is combining radiation and drugs to stimulate the immune system to fight cancer. Or sometimes you might have heard it from news, we call that abscopal effect. And we have seen sometimes very dramatic effect from the combination of both treatment, radiation and immunotherapy. And this is an example of a patient who had melanoma that moved to his lungs, unfortunately, and this was growing bigger and bigger while he was getting immunotherapy. And he had another area in the neck that was quite bothersome to him, and that was treated with radiation. And a few months after finishing that treatment, the immunotherapy actually started working better, and it almost entirely eliminated all the cancer cells from his lungs afterwards. Do we see this kind of response often? Not really. This is really an exceptionally good response to the combination treatment. So we are currently working very hard on understanding why this happened to some patients but not others, and how can we make sure this happens more often than not. So stay tuned on that front. Another very promising technology or radiation technology is what we call flash radiation. It's a really, at this moment, more preclinical than clinical, but we're trying to move this into the clinical trial realm. The flash radiation differs from the conventional radiation in that it really delivers a very high dose of radiation in very, very short bursts. Typically less than a second compared to 5 to 10 minutes with conventional radiation. And the beauty of that is we actually found out in animal studies, in some early human studies, that it actually reduces the amount of side effects on the normal tissue, which would allow us to give more radiation and potentially cure more patients while still keeping the side effects low. And this example here is not really melanoma, but a lymphoma in the skin. But this is one of the early demonstration of how this works. So this patient has lymphoma in the skin around the elbow area and received 1 dose of flash radiation. And a few months later, the lymphoma has gone away, and the surrounding skin surprisingly didn't have any atrophic changes or other changes that we sometimes see with high dose radiation. So I think this area is also evolving quite rapidly in the field, and I think we'll hear more about this very quickly in the future. There are other technologies, for example, proton therapy. You might have heard that on the news. Unfortunately, we actually don't have that technology here at UNC, or actually in the state of North Carolina. But it's becoming more prevalent, and it is a different type of radiation than what we typically use, which is X-rays. And there are physical properties of proton therapy that renders it much more desirable sometimes when we treat cancer located deep in the body. And I'll just say MR guided linear accelerator. Some can use MRI instead of CT to guide us in terms of localizing the tumor in real time. It has been shown to reduce the side effects of radiation in some situations, for example, in prostate cancer, again, treating tumor deep inside the body. And there are many, many other technologies that we are working on as well that can potentially be translated to better treatments for melanoma in the future. So those are what I wanted to say to you. And there are a few take-home points I wanted to mention here. It takes a village to provide the best care to every patient with melanoma. And again, I really want to thank all of you for allowing us to be part of your care team. And radiation oncologists are an important part of the team. And radiation can be used to help patients with melanoma in many situations. And its use has been refined over the years. And now we are finding new ways to use radiation to help patients with melanoma. And as you heard, focused radiation can treat tumors that cannot easily be removed with surgically. And oftentimes it is done with very minimal side effects, and working tirelessly to make treatments for melanoma more effective and less toxic in the future. So that is all. And again, thank all of you for being here, and thank all of you for being online. Happy to answer any questions if you have any. Mm-hmm. No problem. Mm-hmm. Yes. Mm-hmm. Well, I don't know if it's going to be better than surgery. So I think it does require a lot of studies in the future. But right now, it seems very promising that it can treat the cancer with very or reduced side effects. So stay tuned on that front. Gotcha. Understood. Mhm. Mhm.
Would it show up in your brain if there's anything, if you had it, would it show on the brain? Or you have to have another-
Yeah, PET scan is typically not the best kind of imaging for brain metastasis because the brain, because we all think very hard, it's very active, and everything in the brain is gonna light up. So it's kind of hard to see brain metastasis on a PET scan. So we do need an MRI of the brain. Absolutely. Yes.
Proton therapy is in visual trauma?
It's not, unfortunately. We don't have that technology here in the state yet, but we're actively exploring the possibility of bringing that to UNC. Yes. Yeah, I think typically when we need to get a PET scan, it's probably the time to get an MRI as well. That is usually we determine when to get it by the stage of the cancer. As the stage gets higher and higher, there's a greater need to know what's going on in the brain, if it makes sense. Or in another situation is when the cancer comes back, unfortunately, and when we sometimes see it in one area of the body, we need to make sure it's not also in the brain. Sometimes yes, but often, quite surprisingly, a lot of the times patients don't have any symptoms until the tumor in the brain gets quite large. So, yeah. Yes.
Did have an SRS 6 years ago this July.
Mm-hmm.
They did my PET, it did not show up, but going into a clinical study for the immunotherapy,
Yes.
I tried to have the MRI then, and it did show up.
Mm-hmm.
4 millimeters. As far as the procedure went, it was one of the most unprocedure procedures I've ever had. I think the hardest part was getting masks made,
True.
but it's very effective and very little side.
Well, thank you so much for that perspective. I intentionally did not mention the mask, but thank you for bringing it up. All right, thank you all.
Hey, that was excellent. Thank you, Dr. Chen. Our next two speakers, I'm hopeful that they're back there since I have not met them in person. We've emailed and talked and such. This is Brianna Castro Giovanni and Carly Bailey, and they are part of our health and wellness team here at UNC. We try to treat the whole body, and we think that physical fitness helps not only your cancer outcomes, but your emotional health as well. So we're really, really excited to have them here. So come on over. Okay. Oh, wait, this is. Go to from beginning. Okay, thanks a lot. And then you can do error. Thank you. Thank you.
Hi, everybody. I'm Bree. Thank you, Paula, for the introduction. Carly and I are going to talk to you about health and wellness at the Lineberger Cancer Center. So first, we wanted to give you a little bit of background of what is recommended for exercise for cancer patients. So the ACSM guidelines for cancer patients and survivors. So ACSM is the American College of Sports Medicine, which is one of many governing bodies that comes out with guidelines for exercise. So the most important thing is just to avoid inactivity. So just be active as you can. But the sort of number recommendation is 150 minutes a week of moderate intensity aerobic exercise or 75 minutes a week of high intensity aerobic exercise. And then resistance training, so using either some weights or just your body weight 2 times a week. And so this is a really cool poster that came out through ACSM, Moving Through Cancer, and it really talks about how exercise can really impact your health and can really also help a lot of side effects and symptoms that you may be experiencing. So, the most common symptoms I think that most of us feel are, the sort of chronic fatigue, cancer-related fatigue, decreased physical function, anxiety, depression, sleep disturbances. Some people also struggle with lymphedema, and then also poor bone health. And so these are all the things that exercise can actually positively impact. And so when we think about exercise, the best is to do a combination of both, right? So a little bit of cardio, a little bit of aerobic, and a little bit of strength training together, along with maybe some stretching or some flexibility, maybe some yoga. So sort of a combination of both really shows the most impact over time. And then, there are some special considerations when we think about exercising, especially if we have cancer. So, if you have bone mets or bone loss, you want to avoid, really high impact movements or any, sort of really intense stretching of any kind. If you do have lymphedema, there are certain exercises that you want to make sure, you're doing safely and appropriately, wearing a compression sleeve and always following your doctor's recommendations. If you're an older adult, making sure, kind of same thing, you're avoiding any high impact movements, but you're also taking into consideration that weight bearing exercise like walking or like squats or stuff like that is all going to help promote the bone building, which is really good as we age. If you have an ostomy, of course, there are some things you want to keep in mind, emptying before exercise, avoiding contact. And then, with really anything, having supervision from a trained exercise professional is always really recommended, or at least guidance from a trained exercise professional. Exercise is also really good for peripheral neuropathy, specifically focusing on, balance exercises, stability exercises. But if you have peripheral neuropathy, it's also important to remember that you are at an increased risk of falling. So you want to make sure that there's nothing in your way when you're exercising that could cause you to trip. If you've had a stem cell transplant, of course, you're at a higher risk for infection. So you want to make sure you're doing maybe in the beginning, some home-based programming, light intensity exercise, and just progressing slowly day to day. And then of course, no exercising if you have a fever or if your counts are low.
Hi, I'm Carly Bailey. I'm the Director for Physical Activity and Integrative Oncology at the Cancer Center. I heard lots of muttering when Bree mentioned what the recommendations for exercise were. So I'm going to talk to you guys a little bit about some of the programs that we have available to help you get towards those recommendations. They're just recommendations. It's important to note that something is better than nothing. So the first program I want to tell you guys about is a program called Get Real and Heal. This program is a community program that's offered in a 12-week session It's a moderate intensity individualized exercise program. We offer strength, balance, cardio, and flexibility training in each of our hour-long sessions. We are open to everybody. So any diagnosis, any stage, no matter where you are in your cancer journey, you're welcome to come to our facility and work out. We have an exercise physiologist on staff who is cancer trained and an expert when it comes to exercise oncology. So no matter what side effects you might be experiencing, she can help you figure out what exercise looks like with your specific situation. We may require your oncologist's clearance, but if you do need that, our program will get in touch with your oncologist for you and help you sort of figure out what that looks like. And then we just ask that you complete our baseline physical assessment, which is provided by our team. So that's really great if you live close. But if you live far away, we now have a remote program that you can join on Zoom. We offer this program 5 days a week on Zoom in live classes. We also record all of those workouts and post them online, so you can access them anytime. And these two programs are not exclusive of each other. So if you can come in person 1 day a week, but not the other days, you can totally hop into our Zoom workouts on those other days and work out with us. Both of these programs are completely free. And between you and me, we're not going to kick you out of the program after 12 weeks. So we have a mechanism set up where you can continue to work out with us for up to a year after the 12 weeks is done, just so that you can really figure out what exercise looks like and get really comfortable working out in a gym setting before you go onto your own home. So the in-person program, Get Real and Heal, is located on UNC's campus, but not at the hospital. It's down at the Outdoor Education Center, which is sort of by the law school. We have free parking available there. And so it's really easy access. There is quite a large hill down to our facility. So if mobility is an issue, you just let our program know and we'll kind of figure out how to get you into our building safely. We underwent major renovations last summer, and now we're all shiny and new. We have new equipment, and it's really beautiful. It was beautiful before, but it's really great now. We have a designated area for weights. And the other really great thing about Get Real and Heal is the community aspect. So yes, we're an exercise program, but we're also a great community. We do potlucks and block parties. We have walking groups that meet regularly. Some members of our community just completed the Tar Heel 4-miler together. We do monthly lunch and learns. Right now we're offering Zumba. I'm working on getting Pilates up and running. We're trying to figure out about Tai Chi. So we've got a lot of stuff sort of in the mix happening at Get Real and Heal. The other thing that we offer through Get Real and Heal is it's a support group called Stronger Together. You do not have to be engaged with Get Real and Heal to come to this support group. We call this our wellness-minded community. So it's just an opportunity to come either in person or you can join us on Zoom and spend some time talking about how cancer has affected your wellness and what wellness means and what that looks like, and bounce ideas off of the group. And it's just a space to chat with other people who are in a similar situation to you. We have a yoga program. We are offering yoga on Zoom 4 days a week, and then in person at our Get Real and Heal facility 1 day a week. So sorry, this slide is just a little bit outdated. We're also working on getting inpatient yoga back up and running. So if you do find yourself inpatient, you may or may not have a yoga therapist up there to work with you. But it is important to note that this program is also completely free. To get started, you just email me, I send you a waiver, and you're in. And you can join as many classes as you want for however long you want. You're welcome to hang around and be a yogi for as long as you want to be. We have a mindfulness program called Mindful Moments. This is a one-on-one opportunity to provide mindfulness. So you just meet with our practitioner at a time that works for both of you. She can walk you through some guided meditation or some guided imagery. Lots and lots of our patients report that this is helping them with their insomnia, their pain, helping manage their anxiety, really just providing you with a tool to sort of promote relaxation in real time when you need it. We also have a whole integrative oncology clinic. So this is the only program that I've talked about that is billed to your insurance. And this is just an opportunity to work with a practitioner sort of on the whole person picture of what you're experiencing. So lots of people who work with Denise, our practitioner, talk about nutrition, talk about supplements. She does a lot of counseling around exercise, helps people sort of figure out the whole person perspective for their cancer experience. So if you're interested in sort of learning more about how supplements or massage or acupuncture or other sort of non-traditional treatments might fit in with your larger oncology care plan, our integrative oncology clinic is the best place to go. I'm going to turn it back over to Bree to talk to you guys about a research study we have going on.
Okay. So Health Score is a study that Carly and I both work on. And it's been around in the Cancer Center for a few years now. And right now it's a randomized research study that offers health coaching to metastatic or advanced cancer patients at the UNC Cancer Center. So if you decided you were interested in this and you wanted to join, you may receive a health coach, and with that, one-on-one individualized health coaching, a Fitbit device. We are giving out right now Inspire 3s, up to 3 $20 gift cards, and access to a study website with resources and tip sheets. So this really cool picture here on the right is an image that kind of helps understand what exactly health coaching is and what exactly Health Score health coaching is. So health coaching is a way to really dive into yourself and talk about anything that kind of falls under the umbrella of health and wellness. So when we think about health and wellness, there are a lot of things that come up: exercise, just overall well-being, your quality of life, your physical space, your connection to other people, maybe your finances, your spirituality, your rest, your nutrition, and there's probably others in here too. So any of those sort of topics would be appropriate things to talk about with a health coach. And with Health Scores specifically, we kind of are interested in these 4 M's on the outer circle here. So motivation: what is really driving a person to create change? What motivates you? What inspires you? What keeps you going, working towards your goals every week? Meaning is all about hope and joy, and how we're looking for that in our everyday lives, and how we're using that hope and that joy to, create the change we want to see and cope with our disease. Mood is really focused around improving anxiety and depression, decreasing stress, also coping. How are we coping with the disease, and how are we coping with how we're feeling on a day-to-day? And what is affecting our mood, right? Maybe sleep is really affecting how we're feeling every day, or low energy is really affecting how we're feeling every day. And then the last one, movement, which we've already kind of talked about a little bit. So how are we moving our bodies, and how are we getting in a little bit of that physical activity? So you may be eligible for this research study if you have been diagnosed with advanced or metastatic disease, you have access to internet, and you are either English or Spanish speaking. So if you decided you wanted to join, how it would work is me and you would have a phone call. I would go through the consent form, which is a lot of what I'm talking about now. It's some additional details. And if you decided, yes, Bree, this sounds great, I'd really love to be a part of this, I would send you the forms to sign electronically. The great thing about this program is it's really completely virtually. You don't ever have to come in. You don't ever have to come to the hospital. You don't ever have to see anybody in person if you don't want to. Most of this is done through phone call, through email, or through like Zoom or video chat. We do offer some assessments at Get Real and Heal, which Carly had talked about. So if you would like to do some of the assessments in person with Gabby, our exercise physiologist, you're more than welcome to. If you'd like to just do them at your home, that's also a possibility. So it's completely virtual. It's completely free. You don't have to pay to be in this research study. And it's completely optional. You don't have to do it if you don't want to. So the physical assessments are at the baseline 3 and 6 month time points, which is the length of the study, 6 months. And these are actually the same assessments that you would do if you were enrolling in Get Real and Heal. So for a lot of people, they want to do both. They want to do Health Score and Get Real and Heal. That's awesome. You can do both. and the assessments are the same, which is great. You can do your assessments and now you're on both programs. The assessments include a couple of walking tests, a sit to stand, balance, a cognitive assessment so we can test your memory. And we do these things again at the 3-month and the 6-month mark. And what we're looking for is improvements. We want to see that you can walk a little bit farther than you did at baseline, or your balance got a little bit better. Your memory maybe improved a little bit. Along those same time points, you'll have a survey that you'll take. This survey is a little bit lengthy, but we do give you a $20 gift card saying thank you for taking this. And this survey really assesses all areas of health. So back to that picture of the wheel, all of this sort of rainbow colors, that's what we ask you questions about. Your well-being, your quality of life, your finances, your physical health, your mental health, and spiritual health. And what we do with that information is built into these surveys are triggers for alerts. And if you are maybe struggling with some of your finances, or you really would love to talk to somebody about, your stress, whatever it may be, our program gets that information. I reach out to you and I say, hey, how can I connect you to someone? Is there anything I can do to help? And we can connect you to resources within the Cancer Center. A lot of them that Carly already talked about, resources in your, maybe in your community, whatever is really available to you, or we can send you sort of our study tip sheets and resources that we already have. So that's sort of what we do with that information, why that information is important. And then you'd be paired with your health coach. If you were randomized to the group that gets a health coach, you would get your health coach. And you would work with that health coach every single week for 6 months. You would have weekly phone calls where you would just talk about the wheel of health that I showed you here. So you would talk about whatever is on your mind, whatever areas of your health you're really wanting to create change around. And you and your coach would have these phone calls and have these conversations. And your coach is really there to motivate you, to encourage you, to hold you accountable to your goals, to be a sounding board, to be that accountability for you every week. You're going to create goals together. Your coach is going to email you those goals. And then they're going to check up on you next week. And they're going to say, hey, you said you were going to walk 3 times last week. How did that go? And you're going to tell them it went really well, or it didn't go well, and this is why. And then you can talk about that. You'll also get a Fitbit. You'll wear that Fitbit every day. It'll track your steps, your activity. It also tracks sleep. So you can sort of use it to track your sleep if you'd like as well. And then we do have a study website that was built by CHI-CORE, which is a program here at UNC. And there's tons of stuff on this website for you. All of your data, your survey data, your Fitbit data is here. You can see how your numbers are changing over time and you can track that information. You can chat with your coach on the website. You can view any of our tip sheets, from symptom resources, how to self-manage some symptoms at home on your own, other tip sheets and resources for internet resources and all different kinds of things. And there's also a way to watch some of our exercise videos and watch patient testimonials. There's tons of stuff on here. So before I go to the last, that's essentially what health score is. So I kind of talked a little bit about, well, that, you would get the health coach if you were sort of randomized to that group. So because it's a randomized study, there are 2 groups. So that first group that I talked about, you would get the health coach, you would get the Fitbit, you would do the assessments, and you would be on study for 6 months. You may also get randomized to the second group, which means that for those 6 months that you were on study, you would do the assessments, you would get the Fitbit, but you wouldn't get to work with the health coach until those 6 months were up. If at that point you decided, yes, I've done my 6 months, I would like to work with a health coach now, you're welcome to stay on for an additional 6 months and get your health coach. And really what we're studying here in the difference between the groups, why some people might get a health coach and why some don't, is so we can say, how is health coaching really helping? And how is health coaching affecting their quality of life and their physical function? And, what differences do we see? And so far, what we've really seen is that anxiety and depression is way down and people feel more connected to others. Their physical function is a little bit better, but they're just more connected and they're more joyful, and they loved it. So going on to the last one. Do you want to? Okay.
Okay, so we've just thrown a ton of information at you, and maybe you're feeling a little overwhelmed. So we're just gonna pause for a second and give you some health coaching questions. So as you're sort of thinking about where to start and what physical activity looks like for you, think about what you like to do. I mean, not everybody likes to run. Not everybody likes to ride their bike. Everybody is a little bit different. And what we know is that doing something is 100% better than doing nothing. So getting out in your garden or going for a walk to your mailbox, maybe that's what's available to you. That is better than choosing to not do anything today. So a little bit at a time. Also asking yourself, how important is physical activity and physical wellness to you? Maybe you'll find that there's something about being active that would really empower you towards a larger goal. And in that same vein, what does life look like if you're fitter or stronger or had better function? Maybe you're better able to do things with your family or lots of things. There's lots of things that could be the answer to that question. And then finally, what do you need to be successful? Maybe some of our programs can help you be successful and really help set you up on a road that has continual exercise as a part of it. And then, of course, if you want more information about any of these programs, please reach out to either me or Bree. We work very closely together, and so either of us are fine for any questions related to any of these things. And of course, if you have any questions, I think we have a few more minutes. We're happy to answer questions now. Yeah. So if you have a pair of dumbbells, that's great, but we don't require any equipment.
This is the first time I've heard about that this program exists. And I don't know if this is on. Yeah, okay. Anyway, well, I couldn't hear people in the back, so I'm going to just use the mic. I'm just really grateful. And I'm just wondering about schedules and in person. What sort of things do you offer?
Yeah, so for Get Real and Heal, our live, like in-person workouts, we have sort of like at the top of an hour, every hour from 7 a.m. to 3 p.m. on Mondays and Fridays, on Wednesdays from noon to 6. And so you just schedule at a time that works for you. Our remote program, we do Zoom workouts Monday, Wednesday, Friday at 12:30 and Tuesday, Thursday at 8.
Thanks.
Thanks, all.
Thank you. That was amazing. So thank you both. I have to say that my patients who have done either program have found it to be such a valuable, positive experience to them. So I'm really appreciative that they took the time to come and share that with you. Next, we have Dr. Jonathan Sora. He's our assistant professor here at UNC. He's also new to the team, but not new to UNC. He did his training here, and we have been just so delighted to have him as part of our melanoma oncology staff. So, and he wore a bow tie, so I'm very pleased.
Well, good afternoon, everyone. As Paula said, my name is Jonathan Sora. I'm one of the medical oncologists, so the folks who give medicine to treat melanoma. And I'm going to be talking about kind of some of the current treatments as well as some of the future treatments. And to start with, I have to say, so I have a 4-year-old son, and I told him, buddy, I'm doing a show and tell today. I'm giving a talk. He was like, ooh, I want to listen to it. So he started listening to about 30 seconds and he said, Dad, that is so boring. And he instead gave me his stuffed animal to bring up here, which I did not bring, but don't tell him I didn't do that. But all right, let's go ahead and move on. So I've divided my talk into 2 parts. So first of all is kind of what are our standard treatments? What do we have that we can give that's approved right now? And then number 2, what's on the horizon? What are some of the exciting new things that we have coming down the pipe? So I've met some of you guys before, and if I haven't met you, I'm a very simplistic person. So when I'm talking to someone about a cancer diagnosis, I think of treatments for cancer in 3 kind of buckets. So the first bucket is surgery, which Dr. Lilla will talk about later. The second bucket is local therapies, which includes what Dr. Jen talked about, as well as ablation, which is using burning the cancer, as well as some injectable treatments, which we'll talk about. And then lastly, which is most of what I do, which is using medicines to treat the cancer. Now, for medicines, there are three kind of general categories. The first one is chemotherapy, which is what most people have heard of when they think of cancer. And that's basically any medicine that goes in your body that is killing cells that are dividing too quickly. And now it's not specific to cells that are dividing quickly, though it ends up killing both the cancer cells as well as some of the good cells as well, which is where some of the side effects from chemotherapy come from. Now, thankfully, in melanoma, we do use chemotherapy sometimes, but thankfully there have been some advancements that chemotherapy is not our first or second choice of things that we go for. Secondly, we have immunotherapy, which a lot of you probably have heard of, which is basically using the patient's immune system to fight cancer. And we'll talk a lot more about that in a second. And then lastly, we have targeted therapy, which basically means your cancer has a mutation. We have a drug that targets that mutation. We use that drug. And there are lots of different types of that, which we'll talk about as well. Okay, so the first one that I wanted to give credence to of types of medicines that we use, this is a local therapy. And this is called TVEC, or telemagene leheparetvec. Did I say that right? I was looking at Fran because she always taught me, she taught me how to say this. And basically what this is a herpes virus that we actually inject into the cancer. And it kills cancer cells two ways. Number one, it actually directly kills the cancer. And then number two is it actually helps to recruit your immune system to the cancer as well. It actually is pretty well tolerated. Main side effects are some injection site pain, which we can usually control with medicines, and then flu-like symptoms. So low-grade fevers, chills, sometimes some nausea. And then very rarely it can actually cause herpes infections. I haven't personally seen this, but it is reported in the literature some. And this is mostly a treatment for people who have localized cancer, or what we call in-transit cancer, meaning that the cancer has started in one place and it has moved, along the skin surface where we can inject a site, and we inject all the known sites of disease. That is one treatment that we use, and Dr. Lilly uses this treatment as well as Dr. Cooch. Okay, so most of what I'm going to talk about today is kind of big picture mechanisms of how these treatments work. So immunotherapy, as I said earlier, is basically using the patient's immune system to fight cancer. And I promise I'm not going to go into the details of this, but big picture, we have an array of medicines that basically block the checkpoints that our immune system naturally has to keep us from attacking ourselves, to keep our immune system from attacking itself. And unfortunately, cancer cells use these checkpoint blockages to prevent our immune system from attacking it. So the good, smart people around the world came up with an array of medicines that basically block that checkpoint so that the immune system can see the cancer as something that shouldn't be there. And then your immune system fights the cancer. And there are a lot of these now. I've highlighted a couple in red. The one on the far right over there, Opdualag, is a newer medicine that targets LAG3, which is a receptor, or basically a protein on the surface of a T cell that kind of goes through this mechanism. And then on the right at the bottom, you probably have heard of Keytruda and Opdivo, or Pembro and Nivo, as we call them for short, that block PD-1, which is another protein that we use to inhibit this interaction. And then similarly, there's another medicine in this category that's called ipilimumab. That's the one that's on the top there. I didn't put it in red. And basically, instead of blocking the interaction between the white blood cell and the cancer, ipilimumab blocks an interaction between a T cell, and the top cell stands for DC, or dendritic cell. So basically, it's a white blood cell that brings proteins and things that your body is trying to get rid of to the immune system so that it can create a response against it. So it's just another kind of immune therapy. And we often will use these in combination with each other. And then lastly, I just wanted to throw a slide on here about IL-2, which is an old treatment for metastatic melanoma. And this is basically a natural chemical that your body makes that basically tells your T cells, which are a type of white blood cell, to expand and to start creating an immune response. We do still use this. Sometimes this isn't a treatment we use at UNC occasionally, but it's not typically a first or second treatment. Now, as you can imagine, if we are blocking the patient's checks and balances system to prevent autoimmune diseases, basically to prevent the immune system from attacking you, we can cause problems. And this is a diagram that I learned as a resident, as a fellow, where basically anything is possible. We go through the list of side effects that are possible, with the most common ones being tiredness, rashes, diarrhea, and thyroid problems if the immune system gets revved up against those things. But as you can see, really any part of the body is possibly susceptible to immune therapy toxicity. So whenever you're seeing a medical oncologist on these treatments, we're getting blood work regularly. We're also doing a really thorough history and physical exam to make sure that we're not, to kind of screen for these types of side effects. Okay, so that's immune therapy. And then now going into the third part of the types of medicines that are standard of care for melanoma, we have what are called targeted therapies. And there are a lot of them. The most important one that we care about in our world is called a BRAF mutation. And about 50% of melanomas have this mutation. And as you can see, this is a schematic of what BRAF does. Basically, it's a protein that signals the cell to grow and divide. So normal cells have BRAF in them. So a lot of our normal cells that are not cancerous have BRAF in them. But when that protein gets mutated, it continues to create that signal and continues to cause cells to grow when they're not supposed to. So again, there were smart people in the world that created basically pill medicines, which are those top three up there, that block BRAF. Now, what we learned is that if you give those by themselves, they tend to cause a lot of side effects, particularly rashes was one major one. So then we learned that if we give these in combination with a MEK inhibitor, which is the next protein down in this pathway, and gave two pills together, or two treatments together, that it was more effective and with less toxicity. So these are kind of the 6 drugs that we use to target the BRAF mutation. And for any patient who has an advanced melanoma, usually stage 2 or higher, this is something that we standardly check here at UNC, either with a stain of the patient's pathology, or with DNA sequencing, where we can actually send it off to a lab and they will look to see if you have this mutation. And this is where I give you the long list of all the other drugs. There are many, many more than this. But basically, when folks have advanced melanoma, it's pretty much standard of care now for us to send people's melanoma off for sequencing, which allows us to see if you have any of these targetable mutations. And it gives us just another idea of what kind of treatments we could offer. Often these treatments here are used after we get through other types of treatments, but it's always nice to know early on what our options are. Okay, so that is kind of standard of care. That's kind of a broad overview of what the first couple of treatments might be for someone with a more advanced melanoma. Now I want to move into some of the more, I guess, newer age treatments, or kind of what's on the horizon. And the first treatment I want to talk about is called TILS therapy, or tumor infiltrating lymphocyte therapy. And basically the idea behind this is that your immune system, even before we give it any treatment, is interacting with the melanoma. It's trying to kill it off because it's in some ways senses that it shouldn't be there. So your immune system sends white blood cells into the melanoma, which are called TILs, tumor infiltrating lymphocytes. And this is something that we actually look for on our pathology slides, because it does give us a sense of how much your immune system is interacting with the cancer, how inflamed the cancer is. And then, more recently, we've thought, well, why don't we see if we can expand those white blood cells, those ones that have specifically gone into the melanoma, to see if it gives us any way to treat melanoma in a new way. So what they're doing now is they're actually taking a patient's melanoma, taking it out of the patient's body, extracting the white blood cells that are inside the melanoma, and then expanding them in a laboratory. So, making more of those white blood cells. And then basically we suppress the patient's immune system just a little bit, basically to allow those tumor infiltrating lymphocytes to get back into the patient. And then we infuse those lymphocytes back into the patient. And the idea is that it helps us to kill melanoma cells in a new way that we haven't done before. And this is just a brief schematic of a recent clinical trial that has basically randomized patients who've progressed through some of the standard treatments that we use for melanoma, particularly certain types of immunotherapy. And they either gave people on the left side more of a standard treatment, which is ipilimumab, so a immunotherapy medicine, or on the right side, they gave them this TILS therapy that we just talked about. And as you can see, just to give you a couple of big ideas, the response, meaning how much did the cancer shrink, what percentage of the cancer shrank with this treatment. You can see it was about 50% with the TILS therapy, where it was only about 20% with standard of care. And then progression-free survival basically means how long until the cancer grows. How long does it help to control the cancer? And as you can see, it was double with the patients who got TIL therapy over the patients who got ipilimumab. And basically, it seemed like so far that people had better quality of life with the TILS therapy rather than ipilimumab with similar types of side effects. So to go along with this, sorry, I forgot to put this on a slide. This is something that the FDA is actively working on and trying to figure out, how and when this might be FDA approved. The hope is, at least when I was looking at it this weekend, it seems like maybe by the end of the year, this could be something that we could offer our patients. And as soon as it's something that we could offer, it's definitely something we're going to want to try to get here. Just as another type of treatment we could give patients who have cancers that are not responding to the other types of treatments that we have. And then the last one thing I wanted to talk about, because there's been a lot of stuff in the news about this, is vaccine therapies. And really, basically, a vaccine is putting something into your body to allow your immune system to create a response to it. And obviously, a lot of the excitement about vaccines has been related to COVID and types of infections. But we can also use this to treat cancer in a lot of ways. And on the right side here, I basically put two ways that we can make vaccines to fight cancer. The first is that you take out white blood cells from the patient, expose them to antigens, which are basically proteins that help the immune system to recognize the cancer, and then put the white blood cells back into the patient via a vaccine. That could create an immune response and allow the immune system to attack the cancer. And then secondly, which is the one that's been more in the news lately, is using mRNA vaccines, similar to like the COVID or the Moderna or the Pfizer COVID vaccines. And the idea behind this is that your melanoma is extracted. We create a personalized mRNA vaccine for the cancer, and then we infuse the vaccine, or you get a vaccine that has the mRNA in it. And the idea behind mRNA is the mRNA goes into the cells. It then, the cells create proteins out of the mRNA, and then those proteins, the immune system interacts with it, creates a response with the idea of controlling cancer. And then this is just one of the more recent clinical trials, which is Keynote 942. Basically, Keynote is anything with pembrolizumab or Keytruda, whenever you see that in the news. And they basically took folks, this dissimilar from the TILS therapy, this is for people who've had their cancer removed by surgery, so more localized cancer. So as you can see, stage 3 or 4 melanoma with lymph node involvement where the cancer has been removed. And those patients were either put on the top one, which is the vaccine therapy plus Keytruda, or the bottom, which is Keytruda for a year, which is the bottom is one of the current standard of cares for patients who've had their cancer removed when they have a high risk of recurrence. And what they found is, this is very early data, is that there was a 44% reduction in the risk of the cancer, reduction in the cancer risk. Sorry, 44% reduction risk of the cancer coming back. Sorry, that's a hard one to say. With the mRNA vaccine plus Keytruda versus Keytruda by itself. And then it actually ended up having about the same amount of side effects with the vaccine versus without. So this is a new exciting treatment. And this is also, I just put a little plug down here. We're in the process of getting one of these clinical trials up here. So this is not a standard of care yet. But this is something that we hope to be able to offer to patients through clinical trials, hopefully with sometime this year. Okay, and then my last slide is just to talk about some of the other things that are out there that things that we're hoping to understand better. So I already talked about TILs and vaccine therapies. The kind of another area of interest is what's called fecal transplant. So there's been a lot of data out now that the patient's GI microbiome, so basically the bacteria that are living in your gut, affect how your body creates a response to immune therapy. So we're trying to figure out that if we change the gut microbiome, either by putting in, doing a fecal transplant, which is not as bad as it sounds, I promise. Basically, they give you a freeze-dried pill and they actually put it in there. It's not as bad as it sounds, promise. That it could allow you to overcome immune response resistance. The next one down is called CAR T therapy, which basically, long story short, that is where we take patients' white blood cells out and of the body, and then we engineer them to fight the melanoma. This is a really exciting treatment that's actually standard of care in lymphoma, multiple myeloma, and in certain types of leukemia. But we're looking to try to get this into solid tumors as well. So melanoma is one of the areas where we're hoping to do that. Similar. So in CAR T therapy, they're actually engineered. So it's actually a engineered change. Whereas with TIL therapy, we're just taking out the white blood cells that, that are already in the melanoma, expanding them and infusing them back in. We're not changing them at all. That's the only difference. That's above my pay grade beyond that. Next thing down is, so, unfortunately, with a lot of these treatments, they don't work for forever. So what we're trying to do now is understand, why do these treatments stop working, and what are things that we can do to create an immune response in people where the immune therapy is not working anymore? Can we add something to it? Can we create a new immune therapy, a new checkpoint? All these things are things that are going around in trials right now. And then lastly is, when people get their DNA sequencing back, almost everyone has mutations on it, but a lot of those mutations are not actionable, meaning that I don't have a drug that I can give you that's either FDA approved or that's coming down the pipe. So we're constantly learning about new mutations and how we can use those mutations to fight cancer. These are my kids. Gotta put it. Any questions? I know went a little over time. Yes, sir. Yes, of course. So there are 4 stages of melanoma. And I like to think about it as 1 being the least advanced and 4 being the most advanced. So stage 1 typically means that it's a very thin tumor. We know that people who have thicker tumors, meaning that the further down the melanoma invades, that raises the stage as well. So very thin tumors. Stage 2 and stage 3 is either a very thick tumor, or when there are lymph nodes involved. That's all most stage 3s. And then stage 4 is when the cancer has spread from where it started to another part of the body. That's the basics. Now, if you look at melanoma staging, is actually pretty complicated, but that's the the nuts and bolts of it. Wow. Right. Wow. Amazing. And these are the kind of stories that we love to hear. And this stuff does work. It really does. Yeah, possibly. Yeah. It could either have been a recurrence, or it could have been a new melanoma altogether. And it's hard to know which of those it was. Yeah. I am excited about these TIL treatments. I think that this is a very personalized way to think of cancer and to think of how to treat these types of melanoma where it's not working and the standards of care is not working. And at least the data that I've seen has been very exciting. So I look forward to this getting approval and for us to be able to offer this to people. Yes, ma'am.
Hey. And I have seen so long. But the main thing, no matter what stage you're in, is your outlook every morning. Be positive.
Yeah.
God's not good at you. And the people at the field, and I'm thankful for them. But if you get up in the morning, you're willing to say, oh, this might be the day, I might not be this tomorrow. It's very difficult. And I try to be optimistic. I'm here on this side. A little bit right. Okay. So long. And now it's back at something that. Anyway, they'll treat it somehow. I don't know that. Maybe it's not your thing. I don't know. I'm not looking forward to it, but another other thing happening to this body that I don't want to do. Hearing high. Amazing how I get across. God is in control of your life. I know y'all know doing too. But you need to be control, and you should let him have the driving seat for you. And that's just not what you want.
Well said. Yes, ma'am. It's Merck. That's the company. Yeah, I'm not, it would. From being like FDA approved. It's a good question. So we're hoping to get into that was a phase 2 trial. So phase 2 basically means, well, phase 1 means, is it safe? Phase 2 is it better than what we're currently doing? And phase 3 is it better in a large population? So the trial that we're trying to get is a phase 3. So it'll be a few years before it becomes FDA approved, that would be my guess. Yes, sir.
Yeah, because because COVID vaccine was an mRNA modifier, is it likely that it caused less people to get melanoma, or more people get it, or no effect, do you think?
I don't think it would have any effect, would be my guess. But I don't know.
Would you break down what progression-free survival rate means? Because it's measured in months and you'll show something like this is 3 months. So it's like all this treatment in 3 months, right? And then this is so much better because it's 7 months. So if you could
Sure.
explain that, that'd be helpful.
Of course, yeah. So if you got, and I'm sure a lot of you actually pull up the studies and try to look at this stuff. And I think this is one of the most important numbers in cancer. What is progression-free survival? And basically it means that if I start my Opdivo for myself today, how long does it control the cancer before it starts growing? And if it starts growing 7 months from now, progression-free survival is 7 months. Most trials base it from the day you start treatment until the cancer starts growing.
So that's an average?
That's an average.
That's a mean.
or-
And so
yes.
I don't know, like the standard deviation, like can you think about like the skew of it? Because I mean, I hear 3 months, of course, it doesn't sound very long. 7 months
Sure.
doesn't sound very long, but I'm wondering, is there a skew on some side that pulls it, would put it in, contextualize that for us?
Yeah, good question. So we usually use median, not mean. So these are probably medians because those are a little bit less, out to skew. We also will often get confidence intervals on either side. And the other thing that we look at a lot is what's called the hazard ratio, which basically a hazard ratio of 1 means it was neither helpful nor hurtful. If the hazard ratio drops below 1, that shows us that overall is a helpful thing. Or if it goes above 1, it was overall a hurtful thing. So those are just other tools that we have to to try to help and make sure that we're not just, it's not one patient who had 20 months and everybody else was like 3 months, and that pushed, pulled the average that way. Is that helpful?
It's helpful for understanding it. It's still a head scratching when I think about what that, like on the median is 3 months, and that's considered helpful. It's just not a very long time, right?
No.
Yeah.
Well, and this is in people who've been previously treated with other things. So one thing we unfortunately know about cancer treatments is that the more treatments that you get, every treatment tends to be slightly less effective. So the progression-free survival, how long a treatment works for someone who's just getting started, it tends to be much longer. But as they've had 2, 3, 4 treatments, every month can matter, unfortunately.
Thanks.
Yeah.
Yep. Sora, Dr. Sora, you just want to stay put? So often you will hear your provider say to you, we're going to discuss your case at tumor board. Tumor board is an unfortunately named entity that we do twice a month here at UNC for our melanoma patients. It's a multidisciplinary conference where we present cases of new patients, challenging patients, patients that may have had surgery and had an unfortunate result. And we all powwow, and we include everybody from radiation oncology, research, pharmacy, our pathologists, our radiologists, a whole bunch of people, and we powwow about each patient. So we're going to do what we call a mock tumor board, a clinical case study of a real patient that we started taking care of about 3 years ago. So I'm going to invite up our panelists and come on up. So we've got Dr. Googe, Dr. Olagan, William, and Dr. Sora. I think that was it. And Dr. Chen. Come on up, Dr. Chen. You almost got out of it, didn't you? Okay. Yeah, we need one more chair. Yeah, we're gonna have to share microphone. We know Dr. Chen, we know Dr. Sora. Dr. Gooch, could you introduce yourself to everybody, please?
Yeah, Paul Gooch, I'm a skin pathologist. And so I'm in charge of the skin pathology laboratory at UNC. And we look at all the melanoma and advanced skin cancer specimens, so biopsies and surgical infections. And we send reports to Jonathan and Dr. Olilla, so the physician's taking care of you all.
We're going to have to share mics, so just pass them on down. William, if you could introduce yourself.
Sure. Hey, everybody. My name is Will Abnett. I'm a clinical research coordinator. So I help all of these guys run clinical trials. So all of the research you've been hearing about, I help administer that, work with you guys to investigate all of this and find some benefits for you all.
I'm Gabriel Ologun. I'm a surgical oncology fellow. I work with Dr. Olela as that does cutting.
Thank you. So again, this is a real case study. This gentleman is a 38-year-old male. He's married with 2 young children, and he works as a software engineer. He came to us actually after he had already started treatment with a local oncologist who lives several hours away. And he came to us for a second opinion, and he said he felt like the message he was getting was kind of doom and gloom, and he said he wanted to live. So he went to come see one of our medical oncologists here. But here's the backstory. In February of 2020, he noticed a mass in his neck. He had recently had influenza, so they said, let's wait and watch, because sometimes lymph nodes get inflamed because they're angry or you have an infection. So didn't get better. In June of 2020, he had what we call a fine needle aspirate, where they take a very thin needle they take a specimen from the mass and send it to the pathologist, and it turned out to be melanoma. There was an unknown primary. So what does that mean? We asked the patient, you know, did you have any history of a mole that turned funky, that somebody removed at some point? He said, nope, not that he knew of. So my first question to our team is, how often do you see a patient that has no known history of skin melanoma? I know, Dr. Gooch, can you speak to that, or Dr. Sora?
It must be 5% or less. You think, Jonathan?
So about 5% or less of our patients come to us with metastatic disease where there's no known history of a primary skin cancer. Okay. So July 1st, he had a PET scan. It's a head-to-toe scan, and you could see somebody asked about the brain. The whole brain lights up because it's busy thinking and acting and using up sugar. And you can see a lot of those dark spots are not supposed to be there. Those are sites of metastasis. So in addition to the left neck adenopathy, which means a lymph node that is not behaving the way it should, he had bony disease in the cervical area, the left and right scapula, shoulder blades, thoracic and lumbar spine, the ribs, both iliac wings, the top of the left leg, and the left acetabolum. And then there was a question if there was a liver lesion as well. The PET scan is not optimal for looking at liver lesions. So we got an MRI of the liver, and there were 3 livers that were suspicious, liver lesions that were suspicious for metastasis. Now, if any of you have ever read your radiology report, they never say anything definite. Worrisome for, suspicious for, concerning for, because truly the gold standard is a biopsy. And because he presented with such widespread disease, we did do a brain MRI and it was normal. Okay. So at that time, they did what we call a lymph node dissection. Dr. Olgan, could you just explain? I mean, it sounds terrible. What does that entail?
So usually, typically, if we want to treat a patient and who has melanoma that has gone to the lymph node, we go in and take all that section or chains of lymph nodes. And these are the chains or the lymph nodes really help us drain our body. There are different fluids that we drain, and the lymphatic fluid drains through the lymph. And we go in and take out all these chain of lymph nodes depending on the location where this cancer is. And it got done here. But again, I think that's another discussion for when or why we do this.
It's actually done at an outlying facility. And we're going to talk about, you know, is that the right thing to do? But you will see, I'm going to use my fancy picture here, that from this level, this area, there were 3 lymph nodes removed and 2 had melanoma. This level, there were 8 lymph nodes removed, 2 had melanoma. And there was something called extracapsular extension, we're going to talk about in a moment. The other 33 lymph nodes that were removed had no melanoma. And they also were very thorough. They looked at the nasopharynx, they looked at the tonsils. Dr. Chen, could you say something about this, what's called ECE, this extracapsular extension? Like, why is that important?
Yes. So when cancer spreads to the lymph nodes, initially they usually reside within the capsule, and each lymph node has a capsule in it. And as cancer grow inside those lymph nodes, sometimes they can stretch outside those capsules, and this is usually a bad feature, suggesting that the cancer is not only growing fast, but also after the surgery, there might be still microscopic cancer cells still left in the where the lymph nodes used to be, and that patients are usually at higher risk of cancer growing back.
So there were 2 other findings that were pertinent. One is a blood test called LDH, or lactodehydrogenase. And you can see it was quite elevated. These are the norms. This was quite high. This LDH is not specific to melanoma, but sometimes we use it prognostically and also to track response. The other thing that they did at the outlying facility was they sent his specimen to a company called Foundation Medicine. There's another company called Tempest. And you may have heard of either one where we send, Dr. Sora mentioned, we send a specimen to that company to analyze, to look at different mutations to see what's targetable. And sure enough, he had the most common mutation, which is the BRAF V600E. So we've got a patient with now stage 4 disease because it's spread throughout the body, including the bones. We have extracapsular extension. We've got a targetable mutation. So what do we do next year? So let's time travel because things have changed over the past several years. Dr. Olagun and Dr. Sora, if this patient presented to you today with that, that FNA that was positive in this very worrisome PET scan, would you have started with surgery or would you have led with some medical treatment?
I can tackle that. So the standard of care now for people who have more widely metastatic disease is actually to give treatment upfront, so medical treatment upfront. And there are a lot of reasons for that. Number one is to try to make the tumor smaller to make surgery potentially easier. Number two is it helps to get control of the cancer because the longer we wait between when we do something and surgery, if they're not on any treatment in that meantime, there's the chance that cancer could spread more. And then number three, it gives us a sense of the biology of the cancer. So it allows us to see how bad of an actor this is going to be. Because if the cancer doesn't respond to immune therapy or targeted treatments, that does unfortunately mean a poorer prognosis.
And for surgery, in cases where you have a widely metastatic disease, we usually reserve it for those who are symptomatic or have, if it's in an area where it's causing a bowel obstruction or there is a bleeding complication from it. So it's not really because of the cancer, but because of control of some symptoms that is causing a disaster. That's when we go ahead of medical therapy.
Dr. Chen, we talked about this extracapsular extension of the neck and the lymph nodes, and also there's a lot of bony disease. He did not have any bone pain at that time. Is there any role for radiation?
Yeah, I think in this case, I would agree with Dr. Sora that we should probably start with some sort of medical treatment to go around the body and treat everything together. As you know, radiation is a local treatment. Suppose we're only aiming at the neck and we're essentially just allowing the cancer at other area of the body to grow. So in this case, even with the extracapsular extension, I probably would not recommend radiation to the neck. The bone is a similar situation, but there is a little more nuance to that. A lot of the times when cancer are in the bones, they cause pain. And in that case, radiation can oftentimes relieve the pain. But in this case, I don't think that's the case. So I would probably not recommend radiation in this.
And Will, this patient presented today, let's say he had no treatment, and he has this BRAF mutation. Are there any trials today here at UNC that you would offer as first-line treatment?
I don't think there are any trials at the moment, but I might put this patient on a list to be considered in the future for some of the things that we have coming up. Discuss with these doctors, see if that fits kind of in the plan for.
All right, so what happened? So July 13th, we started what I call the double whammy, our most powerful combination of immunotherapy, ipilimumab at 3 milligrams per kilo, plus nivolumab at 1 milligram per kilo, plus a medication called denosumab. You'll hear us call this Ipi-Nivo because that's a mouthful. And denosumab is a medication that often is used for osteoporosis, but is also indicated for bone metastasis. So, Dr. Sora, this 3 milligram per kilo and 1 milligram per kilo, it's very effective. I think about 50% response rate, but the side effects can be up to 55% of people getting serious side effects. So can you tell me about this new switch dosing I've heard about?
Certainly. So there are really two ways to give Ipi-Nivo. There's this dose, which I call standard dose. And if you look back at the initial trials that got these drugs approved in melanoma, this was the dosing they used. you would use this dose times 4, and then you would drop to 1 immune therapy after that. But as Paula said, the chance of one of those, I mentioned the big man with all the different side effects. There's about a 50% chance of having a significant side effect with this standard dose. So more recently, there's been a clinical trial looking at what if we lower the dose of the ipilimumab and raise the dose of the nivolumab, because the ipi tends to be the one that causes more side effects. Now, in that trial, they did exclude patients with cancer in the brain. So we wouldn't do that for, it wouldn't matter for him, but it could matter in certain situations. And what they found is that the rate of side effects was more like 35% rather than 50%. And it seemed like the efficacy or how well it worked was about the same. However, this trial was specifically to look at side effects, not whether the standard dose worked just as well as the switch dose. But we often do use the switch dose, and I think it's getting more traction as a standard care for sure.
We talked about research trials. There's a medication called Opdualag, which Dr. Sora mentioned, and I'm going to ask Dr. Gooch to come on up. Dr. Gooch was kind enough to, lab save your specimen for many years. So he was kind enough to get the actual specimen from the patient at the outlying lab and analyze it for our conference today.
So I'm going to show you something that we've been doing that not many places do. And that's to look at the tumors for the types of lymphocytes that are in the admixed with the melanoma to try to get an idea of what's going on. And so this picture is metastatic melanoma, that the man we're talking about. And the pink areas are the tumor, and the white are fat cells. So this is the soft tissue metastasis. And we go a little higher, the melanoma cells are the big pink round. And so we all know melanoma as a pigment producing tumor, but in many advanced melanomas, the cells actually quit pigment and will be pink, white. And you wouldn't know they're melanoma without special stain stuff. But anyway, these are the bigger pink jobs are the melanoma cells. The little red round ones are red blood cells, but then they're little round blue dots. Those are lymphocytes. And then these are the tumor infiltrating lymphocytes. And they're mostly CD8 cells, which are a type of cytotoxic cell. They like to kill other cells, particularly cells that are either tumor cells or virally infected. CD8 T lymphocytes are the cytotoxic cells. And so in this picture on the left are the little round blue ones. Here they're stained with a red stain to show you the tumor infiltrating lymphocyte. And what we've learned is that any tumor infiltrating lymphocyte is a good sign. And there are times when we see melanoma where there are no lymphocytes. And that's a time where the body essentially no longer recognizes cancer cells. And that's the bad. So we can look at other markers on the tumor cells and the lymphocytes. And you all heard of Pembro, that's a PD-1 inhibitor. And so the PD-L1 is the receptor, and PD-1 is like attached to the receptor. And the PD-L1, we like to see it on the cancer cells. So what we've learned is that they may be, but many times they're not. They're actually in the inflammatory. So there are other inflammatory cells in a tumor, like macrophages, that may be making PD-L1. PD-L1 is telling a false signal to don't attack. Go away, calm down, everything. So it's essentially we put words in kind of tumor saying trying to trick the body. Whether what it's trying to do is, but anyway. So here we see that the PD-L1 is actually probably in macrophage, but there are a lot of lymphocytes that are expressing PD-1. And that's telling us that those lymphocytes although they're there, they're not, they're tired. They don't want to attack the tumor. And then the other lag-free you can think of as another marker. It means kind of the same thing. But yeah, I'm a lymphocyte. I'm lag-free and I'm kind of tired and I don't want to attack the melanoma. And so what the drugs do, PD-1 inhibitors, they block that PD-1 or PD-L1 receptor, and that reactivates the lymphocyte, kind of supercharges that attack the melanoma. And the same thing with lag-free. If you inhibit lag-free, you enhance the lymphocyte activity. And
This patient did have lag-3, which is
right,
key.
quite a few, and so it gives the idea that if you wanted to use the combination of therapy, lag inhibitor, that would.
Thank you. So again, Dr. Good was kind enough to test for that lag. And you see that third thing that says up to a lag. So that's a medication that actually you need to have those lag cells in the tumor to be effective. So Dr. Sora, if this patient presented today, because Opdualag is relatively new, would you still lead with ipi/nivo or would you consider Opdualag?
I would probably leave with ipi/nivo still. There's definitely more data, and generally, for at least for standard dose, that the response rates are higher. So in a gentleman who's young, otherwise healthy, and we want to be as aggressive as possible, that wouldn't change my decision for you. But it would be another option down the road if we needed it.
Now he has this BRAF mutation. Why don't we start with pills? I mean, why risk all those terrible side effects, and why not just do pills at home?
Yeah, it's a great question. And either of those would have been an appropriate choice. We know that in general, the BRAF MEK inhibitors, so the targeted treatments, they tend to work faster than immune therapy. So the main time that we will use these pills up front is if someone has what's called visceral crisis, meaning that they're about to have organ failure, or if they're really, really symptomatic. Those are the folks that we need to get a quick response. Very interestingly, there actually are several trials that have looked at, do we give BRAF MEK inhibitors first, or do we give immune therapy first? And people actually live longer if we give immune therapy first. It's something about giving immune therapy after BRAF MEK inhibitor makes immune therapy less effective. So unless we have a good reason not to give immune therapy first, we tend to do that.
All right, so what happened next? This young man actually stayed with us, and he received 3 cycles of ipi/nivo. He had some, we call liver toxicity, some hepatitis, grade 2. There's a grading system on severity of side effects, so it was moderate, but we stopped the ipi part of it and continued with maintenance nivolumab. And it was amazing. His October PET scan, so again, from July to October, a marked decrease in nodal disease, and the bony disease was no longer seen. So that was a pretty remarkable response. And he said he felt the best in forever. So, and I don't know if you could see, but here's the initial PET scan. See all that blackness? And then at completion, this is dark because it's the brain. You've got, your bladder because it's got the dye in it, and the kidneys because it has the dye in it. But it's a beautiful, amazing response. All right, so then 8 months later, still getting maintenance treatment, he contacts us. He's got blurred vision. So we live in a world of badness where, anybody else would say, go see your eye doctor. But he went to the local emergency room. Our worry was that he had brain metastasis, which goes to your question, when do you get a brain MRI? You get a brain MRI usually at initiation, if there's disease progression, or if you are symptomatic. Thankfully, the brain looked fine. He also had an ophthalmology evaluation. And by the way, when he was there, they checked his blood blood sugar, it was 458. Norms are usually like 120, 150 if you've had a meal. So blurry vision is a common side effect or symptom, I should say, not side effect of hyperglycemia. Hemoglobin A1C was 8.3, norm being 4.8 to 5.6, and that's reflective of glucose over the past 3 months. So, whoa. We stopped at the volume. So how frequent, Dr. Sora, can you speak to this, is new onset type 1 insulin dependent diabetes?
Very,
Melanoma.
very uncommon. I'd say less than 5% of people, probably closer to less than 2%. But it is one of those things that I always counsel my patients on because we do see this. And it is a side effect that I don't like to give people, but I also don't want them to know that it's not possible. Most immune therapy side effects are reversible if we stop the medicines. The main types of immune side effects that are not reversible are what I call the endocrine side effects. So the hormone producing organs. If those get inflamed, they tend to stop making the hormone permanently. And that's what happens with people who get an inflamed pancreas. They stop making insulin.
I think, he's doing really well. He saw endocrinology. He has an insulin pump, so he's managing it very nicely. So it's almost 3 years since diagnosis. He continues to get PET scans every 3 months. He feels terrific. He has a new 8-month-old little boy, which brings another question. Fertility. Do we need to be concerned with, many of our patients are beyond childbearing years, but we do have a fair number of young patients. What do you counsel them with as far as fertility, side effects from treatment, side effects to the possible fetus going forward?
So I definitely do not want people getting pregnant while they're on treatment. And as far as immune therapy, there's actually kind of a mixed bag out there about whether this does affect fertility or not. In general, we don't think that it does. However, I always mention this for my younger childbearing of childbearing potential folks. For men as well, and say, do you want to go see a fertility specialist? We have an entire group here that's focused on helping people who have a cancer diagnosis, needing treatment, and needing to talk about fertility. So and this is actually coming up with one of my patients right now, and it's a very hard conversation because we don't exactly know. Whereas with chemotherapy, we know that it affects fertility.
What about with the targeted treatment?
They have a little bit more data that it can be detrimental to fertility. So in general, for younger people who really think that fertility is important to them, we tend to focus on immune therapy more than targeted therapy.
Right. And so, knock on wood, in 3 years, he's doing beautifully with NED, no evidence of disease. What does the long-term data show about his prognosis? Do we know?
Having a response like this is a good thing for sure. And I think it's hard to know. We definitely, I have multiple patients in my practice where they've had a response like this and they're 5 years out and are still considered disease-free, which is amazing. Of course, they're going to be on a very long surveillance plan where we're going to keep an eye on this. And we unfortunately do see late recurrences, but his prognosis is certainly a lot better than it would have been if he hadn't had such a nice response.
Well, you want to come to the microphone?
I think I can probably project for the room.
All right, you got it.
Dr. Starr, if you had a patient who had Evo, had a very strong negative autoimmune response for in the hospital, recovered from all that, but is not responding very well to Evo alone, would you consider going back on the change ratio or reduced dosage of the
Really good question. So it depends. And that's the answer in medicine all the time, isn't it? But it depends on what the side effect was and how severe it was. There are actually guidelines that give us some idea of when it's safe to retrial double immune therapy. So if someone was admitted to the hospital with grade 3 or grade 4 pneumonitis, which is lung inflammation, that tends to be a reason that we don't retry immune therapy again. However, for this patient, he developed an endocrine side effect, which typically means that the hormone producing organ stops working, but then it doesn't really become a problem again. So with this patient, if he were to have a recurrence, I would feel much more comfortable retrying ipi-nivo than if he had a lung toxicity or a heart toxicity. Mhm.
I want to thank our excellent panelists and then. Well, we're running a little bit late, not surprising because our middle name at UNC is we're running late. But if you want to take a 15-minute break and get some refreshments, come back at about 2:30. Thank you so much.